Good evening. My name is Emily Lane. I am a nurse practitioner with CVS Minute Clinic. I'm new to that company. I graduated in May of 2018 from Clemson University, which is in South Carolina. It is a brick and mortar school in Greenville, South Carolina. And so I got my master's from there in family nurse practitioner. And I passed my boards in August of 2018. I guess it's still this year. I've been tutoring in education for over 6 years. When I was in undergrad, I was the peer tutor and peer mentor for my program for 3 years. If anyone was doing poorly in their program, they had to come see me. And so I did one-on-one tutoring with all those students in undergrad. While I was in grad school, I continued to work with undergrad students. I was both a clinical instructor and a classroom instructor. I taught pharmacology and drug dosage. And I've also done private tutoring with master's students, a lot of students from Simmons University and from other various grad schools. And then after I passed my boards, I added in doing board reviews for nurse practitioners as well. So I am certified by AANP. I'm looking to be certified by the ANCC sometime within the next year whenever my bankroll actually catches up for me to afford to take a second board test. But tonight what we're going to do is we're going to do what I call a lightning round. I've done plenty of these on my other Facebook page. You may have been directed there from my Facebook page or from the major group AANP ANCC study group to find this new group that I've made just so it's a little more private. And I can screen everybody that comes in. And so I've approved everyone that managed to request to join the group before 8 p.m. tonight. So I use two major resources when I do my lightning rounds. I use Fitzgerald and I use Leak to do practice questions. So tonight I'm going to be pulling from Leak, the 3rd edition, so it'll be the most up-to-date one. And what I do is I'll ask you a question, I'll read you the answers a couple of times, and then what you do is you type in A, B, C, or D. Okay? And then we'll go over the question, the rationale, how to get yourself to the correct answer, so that you can use that in future questions, so that you can kind of learn how to do it on your own. So it's great to see you all here. We have about 20 people here, so let's go ahead and get started. All right, let's do this. All right, so what I'm going to do is I'm just going to read the question. Again, I'm going to read the answers, then you type in what your answer is, and then we'll go through rationale. If you have any questions, I do try to actually screen your questions because I have it popping up over here on the right side. So if you have a question, I can either answer it or one of you, the other viewers, can answer questions too. It's a really great community and it's really fun when we do this. Okay, so our first question, the positive signs of pregnancy include A, palpation of the fetus and auscultation of the fetal heart tones by the nurse practitioner. B, palpation of the fetus and a positive quantitative serum pregnancy test. C, fetal heart tones and a positive quantitative serum pregnancy test. D, fetal heart tones and feeling of movement of the fetus by the mother. Okay, so this is again, the positive signs of pregnancy include which of these? A, palpation of the fetus and auscultation of the fetal heart tones by the nurse practitioner. B, palpation of the fetus and a positive quantitative serum pregnancy test. C, fetal heart tones and a positive quantitative serum pregnancy test. Or D, fetal heart tones and feeling of movement of the fetus by the mother. What do we think it is, A, B, C, or D? All right, good job, Angel. Good job, Summer. Good job, Kayla. Good job, Angelica and Monica. If you haven't heard me call your name, you might want to guess again, okay? Good job, JR. Good job, Carla. Let's see. Angel, you don't have to put it in once. I do see it. Okay, good job, Shanna. Good job. All right. Yep, so the answer to this, okay, we got about half and half. Some people picked A, some people picked C. The correct answer to this one is A. Okay, so positive signs are direct evidence. It's the most sure that we can be. So it needs to be something like, you can actually feel it. You can, you hear cardiac activity, something like this. So presumptive signs is the least sure that we can be. So I'm presuming that I think I'm pregnant. So that would be things like what I feel, like if I'm the pregnant person, things I feel. So okay, I didn't have my period, my breasts are tender, I'm nauseous, I gotta pee all the time. So it's like things that could kind of be anything, but we could really kind of assume, I would just assume, I think I'm pregnant, I presume I'm pregnant. Okay, so then probably pregnant is things that the examiner finds. So like an enlarged uterus. And then positive signs saying that I am definitely pregnant is, you know, palpation of an actual fetus, like, oh, I can feel a back, I can feel a butt, I can feel, you know, this, that, and the other. I can feel it kicking. You know, I can hear heart tones, I have an ultrasound, things like that. So that is the most positive sign that I can have. So again, it goes presumptive, that's the things the woman feels, probable, which are things that the examiner feels, and positive is like, oh, I am certain. Okay? All right, so Chadwick's sign is characterized by softening of the cervix, B, blue coloration of the cervix and vagina, C, softening of the uterine isthmus, D, nausea and vomiting during the first trimester of pregnancy. What is Chadwick's sign? A, softening of the cervix, B, blue coloration of the cervix and vagina, C, softening of the uterine isthmus, or D, nausea and vomiting during the first trimester of pregnancy. Good, Amy. Good, JR. Good, Carla. Good, Kayla, Irene. Good, Mimi. Good, Valerie. Good, Sharon. Good, Summer. Good, Kayla W. Good, Angel. Good, Erica. All right, good. I think we're done answering. Yeah, good job. Almost everyone got that one. That one was B, blue coloration of the cervix and vagina. So again, that is the blue coloration that can occur. Typically, we're going to see this with increased vascularity and congestion, especially during pregnancy. Think of all that increased blood flow to the area. I mean, you think of, you know, a vein on your arm. What do you see? What color do you see? You see blue. So if we had a whole bunch of increased blood flow to somewhere, that area could show up as blue. So Chadwick's sign is blue, and it's related to pregnancy and increased vascularization. Okay. All right, a 21-year-old college student has recently been informed that he has HPV infection on the shaft of his penis. Which of the following methods can be used to visualize subclinical HPV lesions on the penile skin? A, perform a KOH exam. B, scrape off some of the affected skin and send it for a culture and sensitivity. C, apply acetic acid to the penile shaft and look for acetowhite changes. Or D, order a serum herpes virus titer. So again, we have a 21-year-old with HPV on his penis. Which of the following methods can be used to visualize subclinical HPV lesions on the penile skin? A, perform a KOH exam. B, scrape off some of the affected skin and send it for a culture and sensitivity. C, apply acetic acid to the penile shaft and look for acetowhite changes. Or D, order a serum herpes titer. All right, good Hope, good Kayla R, good JR, good Angel, good Summer, good Angelica, good Sharon, good Shanna, good Kayla W, good Irene, good Monica. Excellent, good. Seems like our answers slowed down. Good. All right, so yeah, this one is we're going to apply the acetic acid to the penile shaft. So that acetowhite changing is actually, that area will become white with the application. If there is a lesion there that maybe is not quite visualized, you apply that acetowhite, you apply the acetic acid and the acetowhite changes occur. Again, it's routine, but we shouldn't do it over and over again on the patients because it can be irritating if you keep doing it over and over. So just do it, you know, one time or so. And it's not, you know, necessarily, it's not absolutely necessary to even do this if we're talking about clinical practice, because it really doesn't change your clinical management of the patient. But what you can do is use the acetic acid and look for the acetylwhite changes. Okay. All right, the following case is going to be followed by questions and multiple choice answers specific to this case. So the next couple of questions are all going to be related to this one patient that we're going to discuss, okay? A 40-year-old female bank teller has recently been diagnosed with OCD disorder by her therapist. Okay, so we have a 40-year-old female, new OCD. Which of the following symptoms characterize this disorder? A, ritualistic behaviors that the patient feels compelled to repeat. B, increased anxiety when attempting to ignore or suppress the repetitive behaviors. C, frequent intrusive and repetitive thoughts and impulses. D, all of the above. Which of the following characterize this disorder? Ritualistic behaviors, compelled to repeat. Increased anxiety when attempting to ignore or suppress them. C, frequent and intrusive repetitive thoughts and impulses. Or D, all of the above. Good Angel, good Tiffany, good Kayla R, good JR. Good Valerie, good Monica. Good Carla, good Mimi. Good Hope, good Erica. Yep. Yep, you got it, Angelica. Yep, excellent. All right, everyone seems to be getting that one right. So all of these are characteristics of OCD. OCD obsessions deals with the thoughts, compulsions deals with the part where you feel like you must do something. So that's where we get the name obsessive compulsive disorder. Okay. Which of the following medications is indicated for the treatment of OCD? So which of the following medications are we going to use for OCD? A, paroxetine or Paxil. B, haloperidol or Haldol. C, lorazepam or Xanax. D, imipramine or Elavil. Again, A, paroxetine or Paxil. B, haloperidol or Haldol. C, lorazepam or Xanax. D, imipramine or Elavil. Which of the following should we use? Good Hannah, good Kayla R, good Sharon. Good Angelica, good Summer. See, good Monica, Tiffany, Shanna, Erica, Tammy, Hope, all got that one. Excellent. Let's see, anybody else? Yep, good Mimi, got it. All right. All right, so most people picked A, which was the paroxetine or Paxil, which is, again, an SSRI. The other three belong to other drug categories, like the Elavil is a tricyclic antidepressant, the Xanax is a benzo, haloperidol is antipsychotic. So what we're really looking for to treat OCDs is something like Paxil or Prozac. Those are 10 of the 2 best ones on the list for obsessive and compulsive disorders. The only thing you really have to look out for with Paxil is, I always remember, is Paxil packs it on, as in you're going to gain weight with it. So that's kind of the unfortunate side effect, because it is pretty invasive and it's very common that Paxil does cause weight gain. You also don't use Paxil in the elderly population, okay? But SSRIs are going to be our best bet for OCD. Again, Prozac and Paxil being up there as some of the best ones. Okay, so moving on from that patient, we'll move on to another question. All right, this is again about health promotion. You would advise an 18-year-old female student who has given a booster dose of MMR at the College Health Clinic that A, she might have a low-grade fever during the first 24 to 48 hours. B, she should not get pregnant within the next 4 weeks. C, her arm will be very sore at the injection site for 24 to 48 hours. D, her arm will have some induration at the injection site in 24 to 48 hours. So again, you would advise an 18-year-old female student who has been given a booster dose of the MMR at the College Health Clinic that A, she might get a fever. B, she shouldn't get pregnant. C, arm will be sore. D, arm will have some induration. Which of the following should we advise this patient? Good, Tiffany. Good, Hannah. Good, Angel. Good, Summer. Good. Good, JR. Good, Kayla R. Good, Carla. Good, Sharon. Yep, Mimi. Shanna, you got it. Angelica, you got it. Excellent. Yeah, most of you guys got that one right. Again, she should not get pregnant within the next 4 weeks. Again, the R in there, it's not about the MM, it's about the R, because rubella can cause a syndrome to the fetus, which is incompatible with life if they get that within the first, trimester. So the R is the big deal about the MMR with the pregnant women. That's the part that we're trying to avoid exposure to, so they don't get that rubella syndrome. That will, cause the either a miscarriage of the fetus or severe teratogenic effects that will make the child incompatible with life after birth. All right, so we should not give it MMR to people who are pregnant, and they should use contraception for 28 days in order to prevent pregnancy or within that time period. Okay. Next is geriatrics. A 68-year-old woman is suspected of having Alzheimer's disease. Which of the following is the best initial method for assessing the condition? Which of the following is the best method to assess for Alzheimer's? A CT scan of the brain. B, Folstein MMSE or the mini mental status exam. C, patient history obtained from family members and close friends. Or D, EEG, or electroencephalography. Okay, so again, which one of these is the best initial method for assessing for Alzheimer's? A, CT scan of the brain. B, Folstein MMSE. C, patient history obtained from family members and close friends. Or D, EEG. How should we assess initially for Alzheimer's? Best initial method for assessing the condition. We don't know if she has it. We would like to assess if she has the condition. Initial assessment. How are we going to assess for that? A, with a CT scan. B, MMSE. C, patient history from family members and close friends. Or D, EEG. All right, I was expecting a good mix between C and B, and I definitely got it. Okay, so the MMSE is definitely used for assessing someone who has dementia. So if we don't know if they have it yet, looking at the family and close friends history is actually going to be the most helpful for us. So the daughter comes in and say, hey, mom is, forgetting where she put her keys. She can't, balance her bills. She can't balance her checkbook, can't remember to pay her bills, that kind of thing. That's going to be more helpful with us in the initial diagnosis. So the answer to this one is actually C, patient history obtained from family members and close friends, where later on we're definitely going to use the MMSE to determine how severe their dementia may be, whether they're, 26, 28 normal, less than 25, where are we hanging out on our MMSE? Carrie, me too. Can I have both, please? But the key word in that question that's trying to quote throw you off is initial. So if I don't have any data whatsoever other than this patient is coming in to be assessed for dementia, what am I going to want? I'm going to want to assess, the patient family to see if they can give me some positive inclination that this patient has Alzheimer's. All right. Next question is genitourinary and some renal stuff. All right. A 55-year-old woman who has had type 2 diabetes for 20 years is concerned about her kidneys. She has a history of 3 UTIs within the past 8 months, but is currently asymptomatic. Which of the following is the best course to follow? All right, so again, we have a 55-year-old woman, type 2 diabetes for 20 years. She has a history of 3 UTIs within the past 8 months, currently asymptomatic. Which of the following things should we do? A, recheck urine during the visit, send a urine specimen for culture and sensitivity, and refer to a nephrologist. B, order a urinalysis dipstick test to be repeated monthly. C, order a CT scan of the kidneys. D, provide empiric treatment for a UTI. Okay. Again, I'll go over those one more time. A, recheck urine during the visit. Send a urine specimen for culture sensitivity and refer to a nephrologist. B, order a urinalysis dipstick test to be repeated monthly. C, order a CT scan of the kidneys. D, provide empiric treatment for a UTI. What should we do for this patient? Good, JR. Good, Hope. Good, Angel. Angelica, Sharon, Kayla R. Y'all got it. Tiffany, you got it. Monica. Good, Carla. Good, Shanna. Excellent. Excellent, excellent. Yeah, definitely anytime you have more than 3 UTIs within a year-long period, that's kind of a one-way ticket to a nephrologist, because no one should really be having that many UTIs within a year. So again, 3 is kind of your threshold. If you hit 3, you're going to refer that patient to a nephrologist, especially if they're diabetic. I mean, this patient's definitely at risk for recurrent UTIs. You're also going to, if you're in the clinical setting and you're thinking about what else can you do, you're also going to check like A1C, have them maybe bring in their glucose monitor so you can download their data, or if they're doing it in a paper log, have them bringing that in, just to kind of assess and see what their sugars have been, because there's possibility that their sugars are sky high, or they're dealing with some uncontrolled diabetes. And you know, sugar is a great breeding ground for all these bacteria, so they're definitely at increased risk. And we want to make sure that their diabetes is in control, in addition to referring them to a nephrologist, because there could be some other kidney damage going on there. You might want to do BUN, you know, creatinine, all that kind of stuff too, before, you know, sending them off. All right, but we definitely need referral, because remember, what are we looking for on the boards? What are we being tested on? They're wanting entry-level knowledge. What if I walk in on my first day of my job? What do I need to do in order to be successful? And that is just us being able to recognize red flags, you know these criteria, being able to treat basic simple things like a slew of infections, acute care visits, and managing major illnesses like diabetes, hypertension, thyroid illness. And that's really what the boards are looking for, is our ability to manage those things safely. Okay, they're not looking necessarily for us to treat and put the unicorn illnesses out there and these major complex things. Okay, so entry-level knowledge, that's what we're looking for. So don't try chasing the unicorns right now. Really stick with the, okay, I hear hooves, must be a horse. Okay. So again, as a nurse practitioner, our job is to diagnose and treat or refer. And that's kind of, again, what the boards are looking for is, here's diagnose and treat the normal stuff. Hey, this is when it's not you anymore, it's time to refer it. So looking at those 2 options. All right, our next question is going to be about health promotion. A nurse practitioner is giving dietary counseling to a 30-year-old male alcoholic who has been recently diagnosed with folic acid deficiency anemia. Which of the following foods should the nurse practitioner recommend to this patient? A, tomatoes, oranges, and bananas. B, cheese, yogurt, and milk. C, lettuce, beef, and dairy products. Or D, spinach, liver, and beans. And I'll do it one more time. A, tomatoes, oranges, and bananas. B, cheese, yogurt, and milk. C, lettuce, beef, and dairy. D, spinach, liver, and beans. And all we're looking for is which of those are high in folic acid, because that's all the question's really asking for. I don't care that he's an alcoholic. I don't care that he's 30. You know, that stuff. It's really just asking me for which of these foods are high in folic acid. So I can toss all that rest of the information out. That's distractors. It's extra. We don't need it. Good. Good, good, good. I'm seeing good things almost all the way down. Good. Yep. So foods that are high in folic acid would be D, spinach, liver, and beans. All of our dark leafy vegetables have a lot of the B vitamins in them. Folic acid is one of the B vitamins. It's B9. So a lot of pastas, breads, and cereals are also fortified now with the folic acid. But again, the answer is D, spinach, liver, and beans. Those are all rich in our folic acid. Okay. All right. Next question, pediatrics. A 14-year-old female adolescent is worried that she has not started to menstruate like most of her friends. During the gynecological examination, the nurse practitioner tells the mother, who is in the room with the patient, that her daughter is starting Tanner stage 2. What are the physical exam findings during this stage? So all this question is really asking me about is, what does Tanner stage 2 look like? We don't care about any of the rest of this distracting information in here, okay? We don't care that she's not menstruating yet. We're not worried about her age. The question is only asking us for, what are the physical findings during Tanner stage 2? So again, distractors are there. So let's read our options. A, breast buds and some straight pubic hair. B, fully developed breasts and curly pubic hair. C, breast tissue with the areola on a separate mound with curly pubic hair. Or D, no breast tissue and no pubic hair. Tanner stage 2. A, breast buds, straight pubic hair. B, fully developed breasts and curly pubic hair. C, breast tissue with areola on a separate mound with curly pubic hair. Or D, no breast tissue and no pubic hair. Which one? Good. Yep, I'm seeing good things all the way down. Yep, good job, guys. Yep. So stage 2 is for my 2 breast buds. Stage 2 is for my 2 breast buds. Okay, so breast buds and straight pubic hair. First we have this kind of fine, soft, straight pubic hair, then it goes coarse, then it goes curly, and then it goes on the thighs, and that's how you go from stage 2, 3, 4, 5. So soft, straight, fine, then it gets kind of coarse, then it gets curly. So that's 2, 3, 4, and then 5 is on the thigh, 5 thigh. That's how I kind of remember my stages right there. Okay. All right, the next one, musculoskeletal neuro. The Fallon test is used to evaluate. The Fallon test is used to evaluate A, inflammation of the median nerve. B, rheumatoid arthritis. D, degenerative joint changes. Or D, chronic tenosynovitis. Which one do we use the Fallon test for? Inflammation of the median nerve, rheumatoid arthritis, degenerative joint changes, or chronic tenosynovitis? Good. Yep. Good, Angel. Good, Hannah. Good, JR. Good, Kayla R. Good, Monica. Yep. Good, Angelica. Good, Carla. Got it, Summer. Again, if I don't call your name, you need to guess again. Good, Tiffany. Good, Valerie. Good, Libanos. Good, Deo. Good, Sharon. Good, Mimi. Good, Shanna. Excellent. Yep, so the answer to that one is A, inflammation of the median nerve. What are we trying to diagnose? What illness are we trying to diagnose then if I'm thinking about inflammation of the median nerve? What are we trying to diagnose? What do we try to diagnose with the Fallon test? What are we trying to diagnose? No options. Just type in what you think it is. Just a little pop quiz. Yep, good, Hannah. You got it. Yep, good, Angel. Yep, you guys got it. Good job, Tiffany. And then what's Fallon look like? Think about that real quick. What's it look like? Yep, good job, guys. What's Fallon look like? What is the thing that they always tell you to think about? What does it look like? What do you do? How do you have them position their hands? How would you describe it? Yep, that's a good way of putting it, Hannah. Yep. Yep, good job, guys. Excellent. Yep, so something like this. Hold it for 60 seconds, see if there's any numbness or tingling. What's the other test that we can use? Besides Phelan, which one's actually more sensitive? What's the second test that we can use for carpal tunnel syndrome? What's the other common test for carpal tunnel syndrome? Yep. Good. Good, Hannah. You got it. Mm-hmm. Exactly. Tenils, which is tapping on the median nerve, which is actually more sensitive and specific to carpal tunnel syndrome. So that's the other one that you need to be familiar with. Again, if you're not familiar with any of the signs or tests that you see when you're reading through some of your review books or materials, what I did and what really helped me most was going to YouTube and typing in you know, Tenils test or McMurphy's or McBurney's or whatever test that I was not familiar with, so ask sign, obturator, blah, blah, blah. If I wasn't familiar with it and I was not very good at like just reading it out of the book and being like, oh, I know exactly what that looks like, I would go to YouTube, type it in, watch somebody do it, and then boom, it was stuck with me forever because I'm a very visual and kinesthetic person, and so YouTube kind of combined those two things to allow me to see it and then like do it on myself, and then it stuck with me forever after that. So if you're not getting a lot of these tests, you need to go on YouTube and look them up and see somebody performing that test. There's a ton of questions on boards about the test because we need to be accurately documenting what test that we are doing, knowing what positive and negative mean so that we are accurately documenting. It's so important when we're talking with insurance companies, when we're talking about provider continuity of care, so the next person that comes in can say, oh, well, their Lockman's wasn't positive, you know, 6 months ago, but now it is. So yeah, definitely something new going on with this knee here. So that's why it's so important to know those, and that's why they want us to know those for our boards. So again, that's my little tip there. Head over to YouTube if you're having any trouble with any of these tests. Okay. Let's go on to our next question. This is OB. So physiological anemia of pregnancy is due to, A, an increase in the cardiac output at the end of the second trimester, B, a physiological decrease in the production of red blood cells in pregnant women, C, an increase of up to 50% of the plasma volume in pregnant women, or D, an increase in the need for dietary iron in pregnancy. Okay, I'll read them again. A, an increase in the cardiac output at the end of the second trimester. B, a physiological decrease in the production of red blood cells in pregnant women. C, an increase of up to 50% of the plasma volume in pregnant women. Or D, an increase in the need for dietary iron in pregnancy. Which of those causes the physiological anemia that we see in pregnancy? Good, Christina. Good, JR. Good, Angel. Yep, good, Sharon. Good, Valerie. Good, Libanos. Good, Carla. Good, Monica. Good, Angelica. Yep, good, Mimi. Excellent. Yep. If I didn't say your name, try a second guess, okay? Good, Shanna. Yeah, good job, guys. So yeah, an increase of up to 50% of the plasma volume in pregnant women. So it is caused by the increased volume of plasma and compared to the red blood cell production, right? Because plasma is what kind of makes up the fluid. It's the solvent, so to speak. And there's less red blood cells. So it looks like there is you know, less red blood cells than normal, but really the red blood cells stayed the same, the plasma increased. So they have this physiological anemia that's not a true anemia. Okay. Respiratory stuff. All of the following are known to cause a chronic cough except. All the following are known to cause a chronic cough except A, chronic bronchitis, B, allergic rhinitis, C, acute viral upper respiratory infection, or D, gastroesophageal reflux disease. I'll read those one more time. A, chronic bronchitis, B, allergic rhinitis, C, acute viral upper respiratory infection, or D, gastroesophageal reflux disease. Which of those are known are not known to cause a chronic cough. This is an except question. There's a ton of those on the boards. Y'all pay attention and read your questions very carefully to see if they're what I call a negative stem. Negative stem questions end with things like except or not. I mean, they're trying to make you pick the wrong answer. Okay? Good, Carla. Good, JR, Krista, Shanna, Valerie, Mimi, Angel, Monica, and Sharon, and Labanos, all on point. All right, if I haven't said your name again, try a second guess. Good, Deo. All right, so most of you picked C, which is the correct answer, acute viral upper respiratory infection. I expected that a couple people would pick B for allergic rhinitis, but think about what allergic rhinitis causes. It causes a chronic postnasal drip, which is very irritating and causes a lot of people to have a cough. So, and again, look at the word chronic. And the question asks for which of the following are known to cause a chronic cough? And C says that it is an acute viral upper respiratory infection. So an acute infection typically won't cause a chronic cough. But I did expect some people to pick the B for allergic rhinitis because it seems like, oh, that's just itchy nose, that's just sneezing. But actually think about that postnasal drip that causes that irritation to the back of the throat and that cough. Okay. All right. Next one is cardiac. Which of the following is a true statement about the effect of aspirin on platelet function? Which of the following is a true statement about the effect of aspirin on platelet function? A, the effect on platelets is reversible. B, the effect on platelets is reversible and lasts only 1 week. C, the effect on platelet function is minimal. Or D, the effect on platelet function is irreversible and lasts 15 to 20 days. So which of the following is a true statement about the effect of aspirin on platelet function? A, effect is reversible. B, effect is reversible and lasts only 1 week. C, the effect on platelet function is minimal. D, the effect is irreversible and lasts 15 to 20 days. Good, Hannah. Good, Tiffany. Good, Carla, JR. Excellent. Good, Sharon, Angelica, and Shanna. Good, Monica. All right, if I haven't said your name, try a second guess. Good, Mimi. Good. Yep, good, Kayla. Yep. All right, so the correct answer to this one would be D. The effect on platelet function is irreversible and lasts 15 to 20 days. What aspirin does to platelets is irreversible. There is no way to alter it once the patient has taken the aspirin, okay? Again, it's not as huge of an effect as something like, Coumadin, Plavix, etc., but it is a lot more significant than a lot of people, treat it as. People are just like, oh yeah, I just started myself on a little baby aspirin regimen. I take one every day because I heard it was good for you. Well, we really don't need everybody on aspirin. We need to assess their individual risk for a cardiac event and then consider putting them on aspirin. Okay? So people really shouldn't be just being like, oh yeah, I put myself on an aspirin regimen. Because it's actually a medication. It does do, irreversible things to your platelets. And we do need to know that our patients are on that. A lot of patients, again, don't report over-the-counter medications. They don't think aspirin's a serious medication, but it really is. So encourage your patients to report all over-the-counter medications. Okay, another lung question for us. All of the following agents are used to control the inflammatory changes seen in the lungs of asthmatics except. All the following agents are used to control the inflammatory changes seen in the lungs of asthmatics except. So it's another negative stem question. Make sure you identify that on your boards. A, albuterol or Prevental. B, triamcinolone, also known as Asmacort. C, montelukast, also known as Singulair. Or D, cromolyn sodium, also known as Ental. I'll repeat those one more time. A, albuterol, which is Prevental. B, triamcinolone, which is Asmacort. C, montelukast, which is Singulair. Or D, cromolyn sodium, which is Ental. Which one of those are not used? Which one of those is not used to control inflammatory changes? Good, Hannah. Good, JR. Good, Libanos. Good, Kayla R. Good, Angelica. Good, Carla. Good, Dale. Good, Mimi and Monica. Good, Valerie. Good change. Yeah, okay, so the answer to this one would be the A, albuterol inhaler, or the Placental, because that one is just a short-acting bronchodilator. It's a SABA. All it does is do bronchodilation, right? We take that one first, and then we typically take our inhaled corticosteroids after that so that we can open first and then get our inhaled corticosteroids all the way down as far as we can into that lung tissue. All right, so again, albuterol, no anti-inflammatory properties, just a bronchodilator. Okay, all right. Rovsing's sign is associated with which of the following? Rovsing's sign is associated with which of the following? An acute abdomen, such as during ruptured appendix, knee instability, C, damage to the meniscus of the knee, or D, acute cholelithiasis. Rovsing's, A, an acute abdomen, such as ruptured appendix, B, knee instability, C, damage to the meniscus of the knee, or D, acute cholelithiasis. Good, Hannah. Yep, all the way down. Good, JR, Shanna, Kayla, good, good. Good, Carla. Good, Angelica and Tiffany, you got it. Yep, good, Valerie. Try again, Libanos. Excellent. All right, so tell me, you know I'm going to ask it. Tell me how to elicit Rovsing's sign. What do I do, and what do I see if it's positive? What do I do, and what do I see if it's positive? Describe Rovsing's to me. Pop quiz. Yep, Hannah, where will the pain be? Yep, good, good. You answered my question. Good, good. Give you guys a couple more minutes to get that typed in. Yep, good job, Kayla R. You got it. Yep, so with Rovsing's, I'm going to push on the left lower quadrant. Pain will be felt on the right lower quadrant. My mnemonic or funky thing to help me remember that is Rovsing. The left side sings about the right side. Okay, so again, we're going to push on the left lower quadrant and expect pain to be in the right lower quadrant. It's going to sing about the other side. That's my little goofy thing to try to remember it. Okay? Alrighty. OB question, which of the following is contraindicated in the care of pregnant women with placenta previa? Which of the following is contraindicated in the care of a pregnant woman with placenta previa? A, an echocardiogram, B, intravaginal ultrasound, C, abdominal ultrasound, or D, pelvic ultrasound? Which is contraindicated? A, an echocardiogram, B, intravaginal ultrasound, C, abdominal ultrasound, or D, pelvic ultrasound? Yep, good job, guys. Got it all the way down. Try again, Kayla R. Yep. Again, I'll read it again. A, echo, B, intravaginal ultrasound, C, abdominal ultrasound, or D, pelvic ultrasound. Good job, guys. Yeah, we don't want to do that intravaginal ultrasound because what is happening with placenta previa, right? That's what this question is asking us really is, hey, what's going on with placenta previa? Okay, so that means that the placenta is, sitting, over the cervix instead of, up on the nice part of the wall where it's nice and secure. So we can't stick anything up in there, right? Because we don't want to cause rupture. Okay, so no intravaginal ultrasound. All right, let's do a GI question. A patient is positive for anti-HCV or hepatitis C virus antibody. What is the next step to further evaluate this patient? So positive anti-HCV. What is the next step that we're going to do to evaluate this patient? A, refer the patient to a gastroenterologist. B, order a hepatitis C RNA test. C, order a hepatitis B comprehensive panel. Or D, the patient is immune to hepatitis and no further testing is indicated. Positive anti-HCV, what do we do next? A, refer to GI. B, order a hep C RNA. C, order a hep B comprehensive panel. Or D, the patient is immune to hepatitis C and no further testing is indicated. Good job, you guys. This is the most common question on hepatitis, something similar to this. A lot of people get really freaked out about hepatitis serology, but this is one of the most common things that you're going to need to know about hepatitis. So getting this one locked in is you're doing something right, okay? Good. Yeah, we're going to test then for the hep C RNA test, the hep C RNA test, okay? Because if they have anti-HCV at this time, we don't know, is it from a vaccine? Is it from, they had it in the past or have it now? So we need to do that hep C RNA to go ahead and look and see what kind of, status basically this patient has as far as their hep C. All right. Okay. Let's see. Musculoskeletal. A 62-year-old woman complains of chronic severe low back pain. She also reports mild episodes of fecal incontinence and numbness to her lower legs over the past week. You would suspect which of the following? A, fracture of the lower spine. B, herniated disc. C, Cauda equina syndrome. Or D, ankylosing spondylitis. So let's review this patient one more time. A 62-year-old woman, chronic severe low back pain. Mild episodes of fecal incontinence, numbness to her lower legs over the past week. Which of the following are we suspecting? Fracture of the lower spine, B, herniated disc, C, Cauda equina syndrome, or D, ankylosing spondylitis? What are we thinking? Yep. Seeing it all the way down. Good job. Good. Excellent. Yep. So a lot of the back pain can be, okay, I can think any of those things. But as soon as I hear anything about either like bladder or fecal incontinence, I'm immediately going to assume it could be Cauda equina syndrome because of that, severe pressure being put on like one of the nerve roots down there at the base of the spine, either lumbar, sacral, or around the coccyx. So we're thinking, major thing here. This is a surgical emergency, so we don't want to leave this untreated because it can cause like permanent issue. So we want to refer this patient immediately to a facility to be treated so that we can get that taken care of. Okay. Next one. All right. We have a 38-year-old multigravida who is at 32 weeks gestation. She calls the FNP complaining of vaginal bleeding, abdominal pain, and uterine contractions. There is no watery discharge. She states that her uterus feels hard and is very painful. Which of the following conditions is most likely? All right, 32 weeks, vaginal bleeding, abdominal pain, uterine contractions, no watery discharge. Uterus feels hard and very painful. When it's a long case study like this, I always like to review everything twice, kind of start forming my own thoughts in my mind about what the answer could be, and then look at the answers, and oftentimes I'll find what I was thinking of is listed there in my multiple choice options, especially in these long scenarios. Okay, so let's look at our options. A, placenta previa. B, placental abruption. C, molar pregnancy. And D, ectopic pregnancy. I'll repeat those. A, placenta previa. B, placental abruption. C, molar pregnancy. Or D, ectopic pregnancy. What are we thinking this is? What are we thinking this is? Good, 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 good. Yep. Mm-hmm. Good, good, good. Yep, seeing the right answer all the way down. Good job, guys. Yeah, so this one is going to be the placental abruption. So again, this one is going to be bright red, very, very painful. Again, we would immediately rule out C and D because ectopic and molar pregnancies, those kind of come to fruition, you know, within the first trimester. They're not going to progress past then, so we are not expecting it to be either ectopic or molar. And those two things show up very early. We would immediately know if they had one of those within like the first, 12 weeks is typically when we can find those out. Placenta previa, that one is not painful, right? Okay, so placenta previa, there's no pain. Placental abruption, lots of pain. Okay, that's an emergency. Need to get going right now. Probably going to be meeting our babies. At least for 32 weeks, that's a pretty good chance, right? And get mama's bleeding under control for sure. All right. Let's see, what do we want to do next? Let's do a pediatric question. When evaluating the blood pressure on both the arms and legs of an infant who has a diagnosis of coarctation of the aorta, which of the following is the correct finding? A, the blood pressure is higher in the arms than in the legs. B, only the diastolic blood pressure is higher in the legs than in the arms. C, the blood pressure is higher in the legs than in the arms. Or D, the blood pressure is lower in both arms than in the legs. That's wordy. Basically, which way is it? Which one's high? I'll repeat those since that was kind of crazy. A, the blood pressure is higher in the arms than in the legs. B, only the diastolic blood pressure is higher in the legs than in the arms. C, the blood pressure is higher in the legs than in the arms. And D, the blood pressure is lower in both arms than in the legs. How many different ways can we word this? How many different ways can we word this? Ooh, I think we got it backwards, guys. Carrie, this is for, okay, so what I'm doing right now is AANP or ANCC clinical content for family nurse practitioners. So plenty of this is applicable to adult gero. It is not applicable to acute care because I do not cover anything that will be done inside of the hospital. Again, that's answering Carrie Pollock's question. So some things will be viable for you, but again, this is not acute care. This is for family practice. Okay, I'm seeing answers all over. So we'll definitely talk about what the correct answer for this one is. So what is coarctation of the aorta? So there's not a ton of, like congenital heart defects on boards. Coarctation of the aorta is actually one of the most common ones that we're going to talk about. So let's talk about it. And Kayla R, yes, C and D are the same thing. That's your first clue. So we can immediately kind of rule those out. Okay, but coarctation of the aorta is an illness. Okay, so you have the trifurcation off the top of the aortic arch, right? Okay, so think heart's here. Here is my aortic arch. Here's my, my trifurcations hanging out over here. Well, this coarctation occurs over here, past that trifurcation. The trifurcation, what does that feed? That feeds my head and my arms. Okay, so my head and my arms have excellent blood flow, quite high actually, okay, because all of my heart is basically pumping into there. There's a coarctation after that trifurcation. It's stuck, it's narrow, it's tiny, it's stenotic. And that means they're getting very poor blood flow to their lower extremities, okay? So pressure is very high in the arms, very low in the legs. There's usually about a 20-point difference in the systolic pressure between the two. So that would make the answer A, the blood pressure is higher in the arms than in the legs, okay? And this is something that we do screen for in all patients. And how we do the screening part is we do a simultaneous palpation of the brachial and femoral arteries, okay? So we're feeling both of those at the same time as our screening method in infants. We're looking for the femoral artery, if it is weaker, delayed severely from the brachial pulse, we are going to go ahead and do the arm and the leg blood pressures and compare them. Do both arms, both legs, and compare them. You should see about a 20-point systolic difference if they are positive. And that means you're going to want to refer them to pediatric cardiologists, you know, have the echoes done, all that good stuff. We actually see this pop up a couple of different times in patients' lives because that coarctation could be kind of minor, okay? So we see it when they hit growth spurts because the coarctation doesn't grow, but the heart and the cardiac output needs for the patient do increase, okay? But that coarctation stays the same. So we see this in 3 places: infancy if it's severe, if it's kind of moderate. We'll see it when they hit their first growth spurt, big growth spurt, like right before they go to school, age 3 to 5. And we'll also see it with their first like pubertal growth spurt because again, they outgrow the cardiac output needs of their heart, and they outgrow that. Basically, they have too much cardiac need for that stenosis. So the 3 times we see a COA kind of pop up and we finally notice it for the first time: infancy, age 3 to 5, and then right when they do that first big pubertal growth spurt, especially in the boys, okay? So that's kind of our breakdown on coarctation. All right, and that is one of the most common cardiac heart defects seen on boards. It's kind of the one you need to know, so be really familiar with that. Okay. All right, let's do one more question. Let's see. Oh, let's see if we remember what we talked about with our first question about probable, presumptive, etc. All right, a young prima gravida reports to you that she is starting to feel the baby's movements in her uterus. This is considered to be which of the following? A, presumptive sign, B, probable sign, C, positive sign, or D, possible sign. Again, we are feeling baby. She says she feels the baby moving. A, presumptive, B, probable, C, positive, or D, possible. Which of the following is that? What did we say? The mom feels it. What did we say? Which one of those categories did we say is where the person who's pregnant feels it? Good, Labanos. Good, Angelica. So the mom says she feels it. Good, Sharon. Good, Deo. Good job, guys. Right. Remember, if mom feels it, if it's something I'm nauseous, I feel my baby move, you know, I miss my period, all of that is presumptive. So this one would be A, presumptive. Good job, guys. Excellent. All right. Well, that'll wrap up our lightning round for tonight. I also, just a couple other things that I offer. So I'll do these a lot more frequently. I took a couple of months off. I was taking care of a sick family member. But I offer, one-on-one tutoring. So if you want more of this, I mean, we can work on practice questions together. I do individual, plan development. I have a nice big form that you fill out, and I help, narrow down exactly what your needs are. I also have system reviews that I pre-recorded. I have covered about 7 or 8 systems within about 4 videos. Those are available to purchase and stream and download on my website. Again, you'll find that link on my Facebook page. You can always message me if you have any questions about that or want the link to my website. It's just fastlanenpreviews.com. So it's just this Facebook page's name, but with a .com behind it. So again, you can stream everything from there, download it. I have subscription packages if you want to do like a one-time purchase and have endless streaming of all my content on the website. So again, message me if you need any one-on-one tutoring. Visit my website if you want to download some of my system reviews where I go into a lot more detail about you know, weeding it out. Here's what you actually need to know. Here's the most important stuff. You know, I've gone through different review books. I've gone through different files. I've done tons of practice questions on my own to really try to weed out what it is that you need to know in order to pass boards. All right, so give us a thumbs up, a heart, whatever you want, and we'll see you next time. Okay? Good night, everybody.